Tracheostomy tube, suctioning. Connect one end of the connecting tubing to the suction machine. Turn the suction device on and adjust the vacuum regulator to less than 150 millimeters mercury. Normally, a pressure between 80 and 120 millimeters mercury is used. If more viscous secretions are present, additional suction may be required. Check the negative pressure of the suction apparatus by occluding the end of the suction tubing before attaching it to the suction catheter. If indicated, increase the supplemental oxygen therapy to 100% or as prescribed. Encourage the patient to take a few deep breaths. Prepare the disposable suction catheter. Using aseptic technique, open the sterile catheter package on a clean surface, using the inside of the wrapping as a sterile field. Open the package just enough to expose the connecting end and connect the catheter to the suction tubing. If a sterile drape is available, place it across the patient's chest or on the overbed table. Do not allow the suction catheter to touch non-sterile surfaces. Unwrap or open the sterile basin and place on the bedside table. Be careful not to touch the inside of the basin. Fill the basin with sterile normal saline solution or sterile water. Perform hand hygiene and don clean gloves. If the patient has a fenestrated tracheostomy tube with a fenestrated inner cannula in place, remove it and replace it with a non-fenestrated inner cannula. Remove gloves, perform hand hygiene, and don sterile gloves. With the dominant hand, pick up the suction catheter, taking care to avoid touching any non-sterile surfaces. Wrap the suction catheter around the sterile dominant hand to help prevent inadvertent contamination of the catheter. Ensure that the dominant hand does not come in contact with the connecting tubing. Check the equipment for proper functioning by suctioning a small amount of sterile solution from the container. With the dominant hand, gently but quickly insert the catheter into the artificial airway with the control vent of the suction catheter open. In patients at high risk for suction-related complications, insert the catheter into the tracheostomy tube until it emerges out of the end of the airway. In patients not at risk for suction-related complications, insert the catheter into the tracheostomy tube until resistance is met and then pull back 1 to 2 centimeters. Using the non-dominant thumb, depress the control vent of the suction catheter to apply continuous suction while completely withdrawing the catheter. Perform one additional pass of the suction catheter if secretions remain in the airway and the patient is tolerating the procedure. Allow a minimum of 20 to 30 seconds between passes for the patient to recover before the next pass. Consider hyperoxygenating the patient between each pass of the suction catheter. At the completion of the suctioning procedure, hyperoxygenate with 100% oxygen for 30 seconds. Return supplemental oxygen to the baseline level. Assess the volume, consistency, and color of the airway secretions. Notify the practitioner of changes in the airway secretions. Wrap the catheter around the dominant hand after the upper airway suctioning is complete. Pull the sterile glove off the dominant hand inside out. The catheter remains in the glove. Pull the other glove off in the same fashion. Perform hand hygiene and don gloves. If the patient has a fenestrated tracheostomy tube, remove the non-fenestrated inner cannula and replace it with a fenestrated inner cannula. Tracheostomy care. Remove the soiled dressing from around the stoma and discard in an appropriate receptacle. Observe the skin surrounding the tracheostomy for evidence of irritation or infection. Remove gloves and perform hand hygiene. Prepare the sterile field on the bedside table and arrange the equipment. Open the sterile tracheostomy kit. Open 2 4x4 gauze packages using aseptic technique. Pour normal saline solution on one package. Leave the second package dry. Open 2 cotton-tipped swab packages and pour normal saline solution on one package. Do not recap the normal saline container. Unwrap the sterile basin and pour a small amount of normal saline solution into it. Open the sterile tracheostomy dressing package. Open the small sterile brush package and aseptically place it in the sterile basin. Prepare a length of twill tape that can go around the patient's neck 2 times. Cut the ends on a diagonal. Lay it aside in a dry area. If using a commercially available tracheostomy tube holder, open the package according to the manufacturer's directions. Hyperoxygenate the patient to maintain oxygen saturation levels above 90%. If desaturation occurs during the procedure, apply an oxygen source loosely over the tracheostomy. Perform hand hygiene, don gloves, and position the tracheostomy collar or T-piece oxygen source loosely over the tracheostomy for ease of reattaching if needed. Remove gloves, perform hand hygiene, and don sterile gloves. Keep the dominant hand sterile throughout the procedure. Tracheostomy care, non-disposable inner cannula replacement. While touching only the outer aspect of the tube, unlock and remove the inner cannula with the non-dominant hand. Drop the inner cannula into the normal saline basin to loosen secretions. Replace the tracheostomy collar or T-piece oxygen source over the outer cannula if possible. To prevent oxygen desaturation in affected patients, quickly pick up the inner cannula and use a small brush to remove secretions from inside and outside the cannula. To facilitate the removal of secretions, hold the inner cannula over the basin and rinse with normal saline solution, using the non-dominant hand to pour normal saline solution. Replace the inner cannula and secure the locking mechanism. Reapply the oxygen source to the patient if needed. Remove the new cannula from the manufacturer's packaging. Withdraw the inner cannula while touching only the outer aspect of the tube and replace with the new cannula. Lock it into position. Dispose of the contaminated cannula in an appropriate receptacle and apply an oxygen source as appropriate. Tracheostomy care. Clean the exposed outer cannula surfaces and stoma under the faceplate. Clean the area extending in all directions from the stoma. Use normal saline-saturated cotton-tipped swabs and 4x4 gauze pads. Clean in circular motion from the stoma outward, using the dominant hand to handle sterile supplies. Dry the skin and exposed outer cannula surfaces by patting lightly with a dry 4x4 gauze pad. Secure tube, tracheostomy tie method. Instruct the assistant, if available, to don gloves and securely hold the tracheostomy tube in place. With the assistant holding the tracheostomy tube, cut the old ties. Take the prepared tie and insert one end through the faceplate eyelet and pull the ends even. Slide both ends of the tie behind the head and around the neck to the other eyelet and insert one tie through the second eyelet. Pull snugly to secure the tracheostomy tube. Tie the ends securely in a double square knot, allowing space for only one loose or two snug finger widths. Insert a fresh tracheostomy dressing under the clean ties and faceplate. Secure tube, tracheostomy tube holder. Instruct the assistant, if available, to don gloves and securely hold the tracheostomy tube in place. Align the strap under the patient's neck. Be sure that the hook and loop fastener attachments are on either side of the tracheostomy tube. Place the narrow end of the ties under and through the faceplate eyelets. Pull the ends even and secure with hook and loop fastener closures. Verify that there is space for only one loose or two snug finger widths under the neck strap. Position the patient comfortably and assess respiratory status. Replace any oxygen delivery sources.